Hey everyone, welcome to The Explainer. If you're a medical student hitting the books, an ICU nurse, or a cath lab pro staring down some seriously complex pressure tracings, you are in the exact right place. Today, we're decoding the Valve Master, which is basically your ultimate guide to understanding the 8 major valvular heart lesions. We're going to take complex hemodynamics, break them down, and make them incredibly intuitive so you never have to blindly memorize these concepts ever again.
Okay, let's dive into this. We've got 5 key steps on the agenda today. We'll start with the heart's mechanical doors, then hit the golden rule of valves, break down systolic lesions, move on to diastolic lesions, and finally take a trip inside the cath lab.
Section 1, the heart's mechanical doors. Think of the heart not just as a muscle, but as this incredibly precise, high-pressure plumbing system. For it to pump blood in one single forward direction, it relies on one-way mechanical doors, the valves. And these doors, they have to snap open and slam shut under literally immense physical pressure thousands of times a day. When they start failing, the whole system's efficiency tanks, and the heart has to work major overtime just to compensate. Now, what's really interesting here is the Valve Master Auscultation Summary. It's basically your ultimate cheat sheet. It packs literally everything into one color-coded place. All 8 major lesions, exactly when the murmurs happen, the best spots to hear them on the chest, and where that sound radiates. It's absolutely brilliant for quick reference. But today, we're not just going to read it. We're going to decode this whole complex mix step by step. We're going to understand the actual physics driving every single box on this chart.
Section 2, the golden rule of valves.
Before we get into the specific diseases, we need a solid anchor. There's one fundamental, super simple concept that's going to make the rest of this explainer incredibly easy to grasp and stick in your memory forever. Here's the golden rule: stenosis versus regurgitation. Whenever you hear stenosis, I want you to immediately think pressure problem. It's like trying to force a fire hose worth of water through a tiny cocktail straw. A stenotic valve is basically a stiff, jammed door that creates a physical roadblock. The heart chamber behind it has to squeeze incredibly hard to push blood through, causing a massive pressure overload. On the flip side, when you hear regurgitation, you've got to think volume problem. This is a floppy, leaky door causing backflow. Blood literally drops backward into the previous chamber, filling it with way too much fluid, which creates a huge volume overload. So keep that locked in. Stenosis equals pressure, regurgitation equals volume.
Section 3, systolic lesions explained. Let's apply that golden rule as we shift our focus to the specific valve failures that happen precisely when the heart muscle is actively working and contracting, just to make sure we've all got the exact same clinical baseline before looking at the pathology. Systole is simply the phase when the heart muscle actively contracts. It's pumping blood from the ventricles out into the massive arteries of the body and the lungs. It's the active, powerful squeeze of the heart. And during that powerful squeeze, 5 specific doors can malfunction. If you're prepping for your RCIS exam or working in the cath lab, you've got to memorize these 5 acronyms: AS, MR, TR, PS, and MVP. These are your systolic lesions. Let's break down exactly what goes wrong with each of them during contraction.
First up, let's compare our systolic stenosis lesions: aortic stenosis and pulmonic stenosis. Remember our golden rule, right? Stenosis means a jammed door and a pressure problem. With aortic stenosis, or AS, you get this classic systolic ejection crescendo to crescendo murmur. Functionally, it's a massive left ventricular outflow obstruction. It dangerously spikes the left ventricle's afterload and systolic pressure, which leads directly to LV hypertrophy. Clinically, you'll find this murmur radiates right up to the carotids and eventually drops cardiac output, causing syncope, angina, or even heart failure. Contrast that with pulmonic stenosis, or PS. It's also a systolic ejection murmur, but it deals entirely with right ventricle outflow obstruction, so it raises right ventricular systolic pressure and causes right ventricular hypertrophy instead.
Next up, the regurgitant systolic lesions: mitral regurgitation and tricuspid regurgitation. Applying our rule again, these are the leaky doors causing volume problems. Mitral regurgitation, or MR, presents with a holosystolic murmur that uniquely radiates to the axilla. Because blood is leaking backward from the left ventricle into the left atrium right during the squeeze, you end up with decreased forward stroke volume and a badly increased left atrial volume. Tricuspid regurgitation, or TR, is also a holosystolic murmur, but it hits the right side of the heart, driving up right atrial pressure and central venous pressure. And here is a fantastic clinical differentiator: the TR murmur uniquely increases with inspiration. Why? Because taking a breath literally pulls more venous blood return into the right side of the heart.
Our final systolic lesion is mitral valve prolapse, or MVP, and it's famous in medical exams for a very specific physical exam trick based entirely on physics. MVP presents with a mid-late systolic click, followed by a murmur. But, and this brilliantly illustrates the hemodynamics at play, watch what happens when we change the patient's physical position. If the patient stands up, we decrease the preload, meaning less blood returns to the heart. With a less full, smaller ventricle, that mitral valve prolapse happens faster, so the click occurs earlier. But if the patient squats down, we increase venous return and preload, stretching and filling that ventricle more. This actually delays the prolapse, meaning the click happens later. It's just a perfect, tangible demonstration of cardiac hemodynamics.
Section 4, Diastolic Lesions Explains.
All right, we've covered the contraction phase, so let's transition smoothly from the active squeeze to the relaxation phase. Once again, establishing our baseline. Diastole is the phase where the heart muscle relaxes and simply allows the chambers to fill with blood. The pressure inside the main pumping chambers drops significantly, and a totally different set of mechanical doors step into the spotlight to either do their job or fail. During this critical filling phase, there are 3 primary diastolic culprits you absolutely need to commit to memory. We're talking aortic regurgitation, mitral stenosis, and pulmonic regurgitation. Let's look a little closer at the mechanical chaos they cause.
Here we have our 2 regurgitant or leaky diastolic lesions. In aortic regurgitation, or AR, blood is leaking backward into the left ventricle from the aorta during that relaxation phase. On your stethoscope, you're going to hear a diastolic decrescendo murmur. But hemodynamically, this creates a massive volume overload in the ventricle. The left ventricle preload skyrockets, the end diastolic volume goes way up, and this creates AR's famous clinical signature, a very wide pulse pressure. Over on the right side of the heart, we have pulmonic regurgitation, or PR. It's also a diastolic decrescendo murmur, causing blood to leak from the pulmonary artery back into the right ventricle. Interestingly enough, PR is most often caused by pre-existing pulmonary hypertension, just stretching out that entire right-sided system.
That brings us to our single diastolic stenosis lesion, mitral stenosis, or MS. Back to our golden rule. This is a stiff, jammed door obstructing flow from the left atrium down into the left ventricle. On a physical exam, you're listening for a very unique diastolic rumble, accompanied by a sharp opening snap. Because the blood is all backed up behind that super tight stenotic mitral valve, the left atrial pressure spikes dramatically. Your pulmonary capillary wedge pressure, or PCWP, goes right up alongside it, causing severe pulmonary congestion. And crucially, all that pressure physically stretching out the left atrium puts the patient at a very, very high risk for developing atrial fibrillation. So we've listened to the murmurs and we've talked through the structural chamber changes. But the real question for clinical mastery is this: how do we accurately measure these invisible forces? I mean, when you can't just rely on your ears, how do you actually see the pressure?
Section 5, Inside the Cath Lab.
This is where theory meets reality. If you're prepping for board exams like the RCIS, or you're making split-second critical decisions in the ICU, this is exactly where you need to focus. Stethoscopes absolutely point us in the right direction, but internal pressure tracings, they give us the definitive, undeniable answer. So the crucial point is learning how to instantly translate visual waveform data into a confident diagnosis. For aortic stenosis, the ultimate cath trap is knowing how to calculate the pressure gradient, which is literally just the left ventricular pressure minus the aortic pressure during systole. What if you see large V waves on a pulmonary capillary wedge pressure tracing? That instantly equals mitral regurgitation. If you're looking at the right atrial waveform and see giant V waves, you're looking at tricuspid regurgitation. And for pulmonic stenosis, the tracing is clearly going to show the right ventricular pressure significantly elevated compared to the pulmonary artery pressure. Let's look at how specific pressure relationships act as undeniable fingerprints for our diastolic lesions, specifically comparing aortic regurgitation versus mitral stenosis. In the cath lab, if a patient has aortic regurgitation, the clue is sitting right there inside the ventricle. You'll see an elevated left ventricular end diastolic pressure, or LVEDP, alongside an increased early stroke volume. Now contrast that with mitral stenosis. The absolute fingerprint for MS is a heavily elevated pulmonary capillary wedge pressure, while the LVDP, the pressure in the ventricle itself, might actually be completely normal. The pressure backup is entirely trapped behind the mitral valve. The tracings never lie, guys. They paint a perfect picture of the plumbing.
We've mapped out the mechanical doors, we've decoded the complex murmurs, and we've broken down the definitive pressure tracings. So I want to leave you with this final provocative thought. As you listen to the next heartbeat with your stethoscope, or as you look at the next wave monitor in the ICU, which invisible pressure force is actually driving your diagnosis?
I challenge you to take this foundational framework, stenosis versus regurgitation, systole versus diastole, and apply it directly to your next clinical case. Once you start seeing the heart as this elegant mechanical pressure system, valvular heart disease goes from a stressful list of confusing acronyms to a perfectly logical, solvable puzzle. Thanks so much for joining me on this explainer. Stay curious and keep learning.